Welcome to The Critical Edge, the no-nonsense podcast breaking down the latest game-changing evidence in trauma and surgical critical care to give you the edge when things get critical.
Absolutely, and it's great to be here.
Yeah, so imagine this, right? A patient arrives in your bay after a 60-mile-per-hour head-on collision.
Right. High mechanism.
Exactly. The airbag deployed perfectly, which, saved them from a fatal traumatic brain injury. But in doing so, it delivered this massive blunt shockwave that essentially bounced their retina off the back of their eyeball.
Yeah, it's a real trade-off.
It is. We built airbags to save lives, but we accidentally engineered, the perfect ocular trauma device. Today, we're diving into the hidden landmines of the trauma bay. We're talking directly to you, the U.S.-trained trauma and surgical critical care surgeon.
Right, the person running the room.
Exactly. You own the primary survey. You are the master of the ABCs, resuscitative thoracotomies, massive transfusion protocols. But when it comes to severe maxillofacial and ocular trauma, the standard rules of resuscitation can actually blind your patient.
They absolutely can.
So we're digging deep into the comprehensive clinical framework laid out by Mielit, Reiser, and Moisidis. We want to translate this highly specialized ophthalmologic data into the rapid-fire decisions you have to make in that crucial first 5 minutes. Okay, let's unpack this.
Let's do it.
Our mission today isn't just to do a basic review of eye trauma. It's to dissect the exact pathophysiology of why standard trauma protocols often fail the eye and, how to adapt your primary survey when the globe is actually at risk.
That is exactly the focus we need. Because, while you are expertly managing the airways, securing breathing, restoring circulation, the eyes are just sitting there, uniquely vulnerable.
Just totally exposed.
Exactly. They are vulnerable not just to the initial kinetic energy of the trauma, but frankly to our own aggressive resuscitation efforts. What we're going to explore today is the profound why behind the specific ocular trauma protocols. We're going to look at the pharmacology of why reaching for succinylcholine during a rapid sequence intubation can be just a catastrophic, irreversible choice for a patient with a compromised globe.
I definitely want to get into that.
Oh, we will. Yeah. And we're going to break down the ischemic timeline that explains why waiting for a definitive CT scan before intervening in a compartment syndrome will permanently kill off retinal ganglion cells.
Wow. So time is tissue, literally.
Always. The eye does not give you the luxury of time, and it basically has zero physiological tolerance for mechanical or pharmacological errors in the trauma bay.
So let's walk straight through the doors of the trauma bay and look at the immediate primary survey. A polytrauma patient rolls in. Before we even get into the microscopic, granular weeds of specific ocular injuries, we have to establish the absolute do-nots.
The cardinal sins, right?
Yeah. Mielit and the team make a critical distinction regarding triage and multidisciplinary collaboration right from the jump.
They do.
If you have an isolated orbital floor fracture, an ophthalmology consult is usually sufficient to develop a functional plan. But when you are staring at extensive panfacial trauma like Lefort fractures involving the nasopharynx, the maxilla, the skull base, you are instantly in complex multidisciplinary territory.
They're calling everyone.
Right. Oral maxillofacial surgery, ENT, plastics, and ophthalmology all need to be mobilized. But while you're waiting for that surgical cavalry to arrive, the initial management of that potentially ruptured eye falls entirely on you.
And this is exactly where those absolute contraindications come into play. It is a highly specific minefield.
Let's hear them.
So, when an open globe injury is even suspected, not confirmed, just suspected based on mechanism or initial visual inspection, there's a strict sequence of missteps you must actively avoid. First, absolutely never measure intraocular pressure.
Just don't touch it.
Do not let anyone pull out a tonopen or apply any pressure to the cornea. Second, never attempt to remove a foreign body at the bedside.
Oh man, they use that taser example in the text, right?
Yeah, it's a chilling example. A taser probe injury that penetrated the eyelid and the anterior chamber. Pulling that out in the ED guarantees a catastrophic prolapse of intraocular contents. You just don't do it.
Right, leave it alone.
Third, never order an MRI if there is even a remote fractional possibility of an intraocular metallic foreign body.
Because of the magnet.
Exactly. The rotational torque caused by that massive magnetic field will cause the metal fragment to literally shred the intraocular tissue as it aligns with the magnet. It's irreversible, permanent architectural destruction of the eye.
And the fourth, do not, which I think is arguably the most critical for the trauma and critical care surgeon who is actively managing an unsecured airway, is avoiding depolarizing paralytic agents like succinylcholine during RSI.
Huge point.
Treating a suspected open globe is like handling unexploded ordnance. You don't poke it, you don't squeeze it, you just shield it. But I want to dig deeply into the pharmacology and the physics here.
Let's do it.
Because, we use sucks constantly for rapid, predictable paralysis in the bay. Why is succinylcholine the ultimate enemy in this specific ocular scenario?
Well, it fundamentally comes down to its mechanism of action at the neuromuscular junction. Succinylcholine is a depolarizing neuromuscular blocker.
Right.
It binds to the nicotinic acetylcholine receptors,
Hmm.
and before it induces the flaccid paralysis we want for intubation, it causes a transient systemic wave of muscle fasciculations.
It's twitching.
Exactly, the twitching. Now, apply that pharmacology to the extraocular muscles, the four rectus and two oblique muscles that intricately wrap around the globe of the eye.
Oh, I see where this is going.
Yeah. When those muscles transiently fire and contract due to the succinylcholine depolarization, they simultaneously squeeze the eyeball from all sides.
Wow.
If that eyeball has a full-thickness laceration or a scleral rupture, that synchronized muscle contraction acts exactly like a fist closing forcefully around the water balloon with a hole in it.
That is a terrifying visual.
It gets worse. The sudden, drastic, uncontrollable spike in intraocular pressure will forcefully expel the uveal contents. You will literally watch the iris, the ciliary body, the choroid, and potentially the retina and vitreous extrude right out of the defect.
You are literally pushing the internal structures of the eye onto the patient's cheeks simply by pushing a standard paralytic.
That's exactly what you're doing.
That perfectly illustrates why the choice of paralytic is a literal sight-saving decision. Rocuronium or another non-depolarizing agent has to be the immediate go-to. You have to bypass that depolarization phase entirely.
100%.
And this structural vulnerability ties directly into the clinical pearl regarding the placement of the Fox shield. The goal is zero external pressure on the globe. Zero.
Precisely. The shield must rest entirely on the solid, bony landmarks of the face, so the frontal bone superiorly and the zygomatic or maxillary bones inferiorly.
Because if it slips,
If the metal shield, or even just the tape holding it in place, impinges on the soft tissue of the eyelid, it passively transfers pressure to the globe, and again, you risk that expulsion of intraocular contents.
it's all about physics.
It really is. Now, beyond the mechanical protection, there is a highly practical pharmacological adjunct that must be initiated right there in the trauma bay.
Okay, what is it?
If you suspect an open globe, administering an intravenous fluoroquinolone, specifically something like levofloxacin at a massive 750 milligram dose, is highly recommended.
Wait, let's pause on that. Because normally in a polytrauma with like an open fracture or a bowel injury, we're reaching for Ansef or Zosyn.
Right, the standards.
Why specifically a 750 milligram systemic dose of levofloxacin for the eye?
Well, the rationale isn't just about broad-spectrum coverage against environmental pathogens. It's about pharmacokinetics. The blood-ocular barrier, much like the blood-brain barrier, is notoriously difficult to cross.
So the standard drugs just bounce off.
Pretty much. The tight junctions of the retinal pigment epithelium actively prevent most systemic drugs from entering the vitreous cavity. In the setting of trauma, you need an antibiotic with high lipophilicity and a low molecular weight.
So it can actually get in there.
Exactly. It needs to actively perfuse into the vitreous and aqueous humors to achieve a minimum inhibitory concentration. Levofloxacin has significantly superior intraocular penetration relative to other systemic antibiotics.
That makes total sense.
You have to stave off post-traumatic endophthalmitis because once a bacterial infection takes hold in the vitreous, the resulting inflammatory cascade will just destroy the retina.
Which is a catastrophic outcome that can result in the complete loss of the eye or, even require an enucleation, even if the primary surgical repair by ophthalmology was completely flawless.
Absolutely. The repair doesn't matter if the infection takes over.
So we've established how to mechanically protect the eye and what pharmacological traps to avoid.
Right.
But knowing how to protect the eye is only step one. Knowing exactly who is at risk and what mechanisms of injury are actually rolling into U.S. emergency departments completely changes how you maintain your clinical index of suspicion.
Epidemiology is key here.
Yeah, if you look at McGuinn's epidemiological data, the numbers are absolutely staggering. We're looking at an estimated 2 million eye injuries per year in the U.S.
That's a massive volume.
It's 6 per 1,000 population. And over 50% of these are treated directly in emergency departments, not specialized eye clinics.
And the demographic distribution of that data is highly specific. It follows a distinct bimodal curve.
Who's in that first peak?
The massive primary peak consists of males in their 20s. This cohort is engaging in high-risk occupational tasks, industrial work, and sports activities where protective eyewear is, often mandated by protocol but practically ignored.
Naturally. And the second peak.
The secondary, much smaller peak is in the elderly population, almost exclusively related to ground-level falls at home. However, it's vital for the triage surgeon to note that in the elderly cohort, the injuries are predominantly superficial contusions. Actual open globes or severe orbital fractures occur in less than 15% of those ground-level fall cases.
Right, so the young guy coming in from the industrial construction site or the high-speed motorcycle crash is your maximum alert patient for a ruptured globe.
Exactly. High kinetic energy.
But let's break down the actual mechanisms that present to the ED. The data shows that foreign bodies make up about 44.6% of presentations, and blunt trauma accounts for roughly 33%.
Yep.
Now, lacerations and punctures, the classic sharp, penetrating trauma we instinctively picture when we think of a ruptured eye, are surprisingly rare, sitting at only 2.3%.
And that 33% blunt trauma figure is the one that should keep trauma surgeons awake at night.
Why is that?
Because blunt trauma is incredibly deceptive. It frequently masks occult posterior ruptures that you absolutely cannot see on a standard primary survey.
And speaking of deceptive mechanisms, we have to talk about motor vehicle accidents. MVAs account for a relatively small percentage of overall eye injuries, but the research highlights a fascinating contradiction regarding automotive safety features.
This is a wild stat.
Here's where it gets really interesting. We know that national seatbelt mandates successfully cut eye injuries in half by preventing occupants from going through the windshield.
Huge public health win.
Right. But the introduction and standard deployment of airbags actually doubled the rate of eye injuries. We literally traded one massive problem for another.
It is the ultimate airbag paradox. And if we break down the exact physical forces at play, it makes perfect pathophysiological sense.
Walk me through it.
So the airbag is essentially a massive, high-velocity, explosive device, right? It's designed to deploy in milliseconds to prevent your skull from impacting the steering column.
Which prevents a fatal TBI.
Exactly. It achieves that goal remarkably well. However, in doing so, it delivers a massive, diffuse, high-velocity, blunt force directly to the midface in the orbits.
Right. The face takes the hit instead.
We've shifted the anatomical injury pattern. Instead of fatal cranial trauma, we are seeing a massive surge in coup contra coup ocular trauma.
Let's define that coup contra coup mechanism in the context of the eye, because I think we need a really clear analogy here. We all know coup contra coup for the brain. The brain physically hits the front of the skull, then rebounds and hits the occipital bone.
Right, the classic mechanism.
How exactly does that translate to a fluid-filled eyeball? It's kind of like hitting a cue ball on a pool table, isn't it? The anterior chamber takes the initial cue stick strike, but that kinetic energy doesn't stop at the surface.
Exactly.
It ripples straight through the vitreous fluid without losing any momentum, and the posterior retina takes the entire secondary impact against the back wall of the sclera.
That is a phenomenal analogy, and it precisely describes the mechanics.
Yeah.
Yeah. The anterior force of the airbag impacting the cornea is the cue injury. This results in corneal abrasions, traumatic hyphemas, or iridodialysis, which is the physical shearing off of the iris root from the ciliary body.
Ouch.
Right. But as that shock wave transmits posteriorly through the non-compressible fluid of the globe, it slams into the posterior pole. That contracoup injury classically manifests as commodio retinae.
And what does that look like pathologically?
Well, the sheer kinetic force disrupts the fragile outer segments of the photoreceptors, leading to cellular edema, retinal whitening, and severe vision compromise, all without a single physical tear in the retinal tissue.
That perfectly bridges into the fracture data discussed by Milet and colleagues, specifically referencing a massive U.S. Army study looking at over 4,400 soldiers with facial and orbital fractures.
Yeah, that's a huge data set.
And these are high-velocity, high-impact kinetic events. They found orbital floor fractures in 37% of cases and medial wall fractures in 31%.
Which makes anatomical sense.
Yeah, as you know, the medial wall is highly susceptible because of the lamina papyracea, which is literally paper-thin bone separating the orbit from the ethmoid sinus.
Right.
But lateral wall fractures were only seen in 24% of cases, and orbital roof fractures in a mere 8%. So my question is, as a trauma surgeon looking at a panfacial CT scan at 3 in the morning, why are lateral and roof fractures so rare, And what is the hidden implication when I actually see one?
Okay, so the lateral wall and the roof of the orbit were formed by incredibly dense, robust, thick bones. The greater wing of the sphenoid and the zygomatic bone laterally, and the thick frontal bone superiorly.
They're built like tanks.
Exactly. Because these bones are so anatomically resistant to fracture, if you see a clear fracture line through the orbital roof or lateral wall on your CT scan, it acts as a massive glaring red flag.
Meaning the force was just astronomical.
Exactly. It tells you that the sheer kinetic energy delivered to that patient's face was off the charts. Therefore, a fracture in these specific locations demands hypervigilance.
What are we looking for?
You must actively assume there is concomitant severe intracranial injury, like a frontal lobe contusion, a dural tear, or an epidural hematoma, and a severe, potentially occult structural injury to the globe itself, simply because of the immense force required to shatter those specific dense bones.
Which brings us to the most dangerous subset of these blunt trauma patients: decoding the occult scleral rupture. Because if 33% of EDI presentations are blunt trauma, and we know these massive kinetic forces are at play, we have to figure out how many of those blunt trauma eyes are actually hiding a full thickness rupture.
Right. It's the ones you don't see.
Exactly. We are moving from the obvious bloody penetrating trauma to the deceptive hidden injuries that will quietly cost a patient their sight if you miss them in the primary survey.
And then you can't afford to miss them.
So let's establish the common language first. The Ocular Trauma Classification Group standards divide injuries into open globe, which is a full thickness wound of the eye wall and closed globe. And then we stratify them by prognostic zones. We don't need to define the basic anatomy, but functionally, Zone 1 is the cornea and limbus, Zone 2 is the anterior 5 millimeters of the sclera, and Zone 3 is everything posterior to that.
Exactly. And the clinical rule of thumb for the trauma surgeon is actually pretty straightforward.
What is it?
The higher the zone of injury, meaning the further back it extends into the posterior segment, involving the critical neurosensory retina and the optic nerve, consequently, the drastically worse the prognosis is for meaningful visual recovery.
But the real danger, the true diagnostic trap, lies in the occult injuries. Werner's research found that up to 25% of potential ruptured globes are occult.
A quarter of them.
A quarter of them. They are completely hidden from a standard external exam. You look at the eye, it might look a little bruised, the eyelids are swollen, but there's no obvious laceration, no uveal tissue spilling out onto the cheek. Yet the eye is completely ruptured.
And to understand why this happens, we have to look at the structural pathophysiology of the globe during massive blunt anteroposterior compression. When an eye is struck by a blunt object, a fist, a steering wheel, a baseball, the globe is squished flat. Because it is a closed, fluid-filled sphere, that sudden compression causes a rapid, massive spike in intraocular pressure.
It has nowhere to go.
Exactly. The eye wall cannot expand, so it will naturally give way and rupture at its structurally weakest, thinnest anatomical points.
And the data gives us the exact measurements of those weak points, which is fascinating. The sclera is not a uniform, rigid sphere.
Not at all.
The ruptures typically happen at the limbus, which is only about 0.5 millimeters thick. They happen just behind the insertions of the extraocular rectus muscles, where the sclera thins out to a mere 0.3 millimeters. And they happen right at the posterior attachment of the optic nerve, which is about 0.4 millimeters thick.
Exactly. And because a rupture behind the rectus muscles or near the optic nerve is physically located deep within the retrobulbar space of the orbit, you will absolutely not see it when you open the patient's eyelids.
It's totally hidden.
It is entirely posterior. This is why the trauma surgeon cannot rely on a visual inspection alone. You must rely on the 5 clinical signs of an occult rupture. Werner's study isolated these high-yield physiological indicators that should instantly trigger an immediate surgical exploration by ophthalmology.
Let's run through those 5 signs because this is the bread and butter of the physical exam.
Let's hear them.
Number 1, visual acuity worse than 2400. That alone is 88% sensitive. Number 2, a lower intraocular pressure in the traumatized eye compared to the normal eye. Number 3, hyphema.
Yeah.
Number 4, a relative afferent pupillary defect, or RAPD. And number 5, vitreous hemorrhage, which is incredibly predictive, sitting at 93% sensitivity.
Those are the heavy hitters.
And alongside those, we look for hemorrhagic chemosis, that boggy, elevated, blood-filled conjunctiva, and a peaked, teardrop-shaped pupil pointing toward the unseen rupture.
Those are the classic hallmarks.
But I want to push back on one of those signs for a second, because functionally it seems totally counterintuitive to a surgeon managing a trauma patient.
Okay, which one?
Sign number 2 was a lower intraocular pressure in the injured eye. Wait, if the eye just sustained massive blunt trauma, if it's inflamed, if it's filling with blood from a hyphema, shouldn't the pressure be skyrocketing? Why would the pressure be lower in a ruptured eye?
It is a great question, and it is fundamentally a matter of fluid dynamics and plumbing. A posterior rupture acts as a pathological pressure release valve.
Oh, I see.
Right. The structural integrity of the globe has been compromised. So while the initial blunt impact caused a massive pressure spike that caused the rupture, once that 0.3 millimeter sclera tears, the aqueous and vitreous fluids are actively, continuously leaking out into the retrobulbar space of the orbit.
It's draining out.
The eyeball is literally deflating. The deflation manifests clinically as a lower, sometimes unmeasurable intraocular pressure compared to the healthy, intact contralateral eye.
That makes perfect sense. The eye is a punctured tire. You can't build pressure if there's a hole in the sidewall. Let's actually pivot on that point and talk about hyphema for a second, because as trauma surgeons, we are often managing competing systemic priorities.
Right, the rest of the body.
Let's say I have a patient with a traumatic hyphema, but they also have a massive pulmonary embolism, or they have a crushed pelvis and desperately need systemic DVT prophylaxis. How does systemic anticoagulation interact with this ocular bleeding?
It is an incredibly difficult clinical scenario. A hyphema is an accumulation of blood in the anterior chamber, usually from a tear in the iris or ciliary body vasculature.
And it clots, right?
It does, but the primary clot that forms is very fragile. The greatest risk with a hyphema is secondary rebleeding, which typically occurs 3 to 5 days after the initial trauma when the initial clot begins to retract and lyse.
So if they are on heparin,
If you systemically anticoagulate that patient, you drastically increase the risk of a massive secondary hemorrhage. A secondary hemorrhage is often much worse than the primary event.
how bad can it get?
It can completely fill the anterior chamber, an 8-ball hyphema, leading to intractable glaucoma, corneal blood staining, and permanent vision loss. You have to carefully weigh the life-saving need for anticoagulation against the very high probability of blinding the patient. It requires an intensive risk-benefit discussion with ophthalmology.
Which perfectly illustrates why the eye cannot be treated in a vacuum. But let's move to the exact opposite problem of a deflated globe, and perhaps the most terrifying adrenaline-pumping scenario for a trauma surgeon managing the face.
Oh, yeah.
If an occult rupture causes a dangerous deflation, a retrobulbar hemorrhage causes disastrously high pressure. We are transitioning from plumbing leaks to the ultimate ocular surgical emergency, orbital compartment syndrome.
Orbital compartment syndrome is the ocular equivalent of a massive epidural hematoma or an extremity compartment syndrome. The orbit is a fixed, rigid, bony box.
Right.
The only soft tissue exit is anteriorly, through the eyelids. If a severed artery starts hemorrhaging into the retrobulbar space behind the eye, or if massive third-spacing edema occurs from facial fractures, that volume has nowhere to go.
It's trapped.
It rapidly accumulates, and the pressure within that fixed bony box skyrockets, pushing everything forward.
The diagnostic criteria are classic and aggressive. You are looking for severe proptosis. The eye is visibly, tensely bulging forward out of the socket.
It's very obvious.
You will find massive resistance to retropulsion, meaning if you gently press on the closed eyelids, the eye feels like a solid rock. It will absolutely not push back into the socket. The eyelids themselves will be incredibly tight, often impossible to open manually.
And if you measure it,
Right. The intraocular pressure, measured by tonometry if the globe is closed, will be markedly elevated. The patient will experience rapidly progressive vision loss, and crucially, you will see a relative afferent pupillary defect, indicating the optic nerve is actively being crushed.
and here is the absolute, uncompromising clinical mandate derived from the literature. If the intraocular pressure is greater than 30 millimeters of mercury, or if the patient has profound proptosis and an RAPD and is unresponsive to immediate medical therapy, a lateral canthotomy and cantholysis must be performed immediately.
Right there in the bay.
And critically, this procedure falls directly on the shoulders of the trauma surgeon or the emergency physician performing the primary survey. You cannot wait for an ophthalmologist to drive in from home. The timeline for irreversible nerve death is just too short.
And here's where I have to push back hard, because you are asking me, a general trauma surgeon, to take scissors to a patient's face based purely on a bedside physical exam.
I know.
The literature explicitly warns about imaging. Do not wait for the CT scan. But we are so heavily trained in modern trauma to scan everything before operating. If I misjudge the proptosis, or if it's just severe periorbital edema without true retrobulbar tension, I am cutting facial tissue for nothing. Isn't the medical, legal, and structural risk of skipping the scan massive?
What's fascinating here is that the hesitation is completely understandable, but it is a vital paradigm shift you have to make. You must weigh the risk of a superficial facial incision against the absolute certainty of irreversible blindness.
Time is vision.
Exactly. The optic nerve and the highly sensitive retinal ganglion cells have a very strict ischemic tolerance. When the pressure in the orbit exceeds the perfusion pressure of the central retinal artery, arterial blood flow completely stops.
So the clock starts ticking.
The clock starts ticking immediately. Animal models and clinical data suggest you have roughly 90 to 120 minutes before those retinal ganglion cells undergo permanent, irreversible infarction.
That's nothing.
Waiting 45 minutes to get the patient to the scanner, acquire the images, and get a radiology read equals dead tissue. Furthermore, the radiographic tenting of the globe, that classic CT sign where the back of the eye looks pointed like a guitar pick because the nerve is tethered and the eye is being pushed forward, is actually only seen in about 29% of genuine compartment syndrome cases anyway.
Oh, wow. Only 29%.
Exactly. The CT scan is not sensitive enough to rule it out, and it takes too long to rule it in. If you have a rock-hard orbit, proptosis, and an REPD, the decision's clinical. You cut.
Let's talk the listener through the exact anatomy of that surgical walkthrough, because it's elegant in its simplicity. You don't need a massive OR setup.
Not at all.
You need a vial of local anesthetic with epinephrine, a hemostat or strong-toothed forceps, and a pair of straight blunt scissors. You inject local into the lateral canthus. You palpate the lateral orbital rim.
Yep.
You take your scissors and make a horizontal full-thickness incision straight through the lateral canthus, literally splitting the connection between the upper and lower eyelids all the way to the bony rim. That is the canthotomy. Then you take your forceps, grasp the lower lid margin, and pull it down and out to put the inferior canthal tendon on severe stretch.
And this is where the tactile feedback becomes the most crucial part of the procedure. You take the tips of your scissors and you physically strum that tight, fibrous band of tissue just inside the incision, much like strumming a tight guitar string.
You can actually feel it.
Oh, absolutely. That is the inferior crust of the lateral canthal tendon. Once you isolate it, you point your scissors infralaterally away from the globe, and you cut it. You will often feel a distinct physical release, a sudden give in the tissue, and the lower eyelid will instantly become lax. That is the cantholysis.
The surgical approach is stepwise. After you cut that inferior tendon, you immediately recheck the tension and the intraocular pressure.
Right.
If the pressure has normalized and the eye feels soft again, you stop. If it is still dangerously high, you have to go back in, isolate the superior crust of the canthal tendon, and cut that as well. And the impact of this bedside procedure is genuinely massive.
It's dramatic.
The data from clinical series show that a successful canthotomy and cantholysis can drop the median intraocular pressure from a catastrophic 50 millimeters of mercury straight down to a safe, perfusing 23 millimeters of mercury. You are literally saving the eye with a pair of scissors and 2 cuts.
It is arguably one of the most satisfying, instantaneous, and impactful procedures in emergency medicine.
And what about meds?
Right, so alongside the mechanical surgical decompression, you must initiate the necessary medical adjuncts to help manage the intraocular and orbital volume.
Like what?
You should be aggressively pushing intravenous carbonic anhydrase inhibitors, like acetazolamide, which decreases the production of aqueous humor. You apply topical beta blockers, like timolol, and you administer systemic hyperosmotic agents, such as intravenous mannitol, to actively pull fluid out of the vitreous cavity via an osmotic gradient.
So hit it from all sides.
But to reiterate the core principle, medical therapy is a bridge or an adjunct to, not a replacement for, immediate surgical decompression when the pressure is critically high and vision is threatened.
Absolutely. Okay, let's follow the clinical logic forward. You recognize the high pressure, you didn't wait for the scan, you successfully performed your lateral canthotomy, and you relieved the compartment syndrome.
Perfect.
The pressure is down, the plumbing is fixed, but when you shine your pen light in, the patient still has a massive relative afferent pupillary defect. The mechanical crush is gone, so why is the wiring still failing?
This is exactly where we transition into evaluating the neurological integrity of the eye, specifically traumatic optic neuropathy.
Okay.
If you have now performed your orbital CT scan, because the pressure is relieved and you have time, and you have definitively ruled out mechanical optic nerve impingement, meaning there's no bone fragment driven into the optic canal, and there's no retrobulbar foreign body compressing the nerve.
Right.
And there was no obvious anterior lesion like a dense cataract or massive hyphema causing the vision loss.
Hmm.
That lingering REPD strongly suggests the nerve tissue itself has been contused. It is a traumatic optic neuropathy, which is essentially a severe concussion of the optic nerve within its rigid bony canal.
And this brings up one of the most fascinating historical controversies in trauma care, which Mila and the researchers tackle head-on: the use of high-dose systemic corticosteroids.
Oh, the steroid debate.
Yeah. For decades, the absolute dogma in ophthalmology and trauma was immediate, massive doses of IV Medrol. We were talking about the old protocol, 5.4 milligrams per kilogram every 6 hours for 3 days.
That's a huge dose.
That is a gargantuan systemic steroid load given to a polytrauma patient who, by definition, is already at an extremely high risk for overwhelming sepsis, stress-induced hyperglycemia, and disastrously poor wound healing.
If we connect this to the bigger picture of critical care, trauma surgeons will instantly recognize the profound parallels here to the historical management of acute spinal cord injuries and the infamous NASCUS trials.
Oh, absolutely.
For years, we threw massive immunosuppressive doses of methylprednisolone at spinal cord injuries, genuinely believing we were halting the secondary inflammatory cascades, reducing edema, and saving axons.
Because theoretically it made sense.
Theoretically, yes. But as the evidence evolved, and as we looked at the massive morbidity data, we realized we were often causing significantly more harm than good, with the resulting pneumonia, sepsis, and GI bleeds. The exact same paradigm shift has occurred in ophthalmology regarding the optic nerve.
It's a classic example of physiological theory crashing into clinical reality. The data synthesis on this evolution is brilliant. Recent meta-analyses, and specifically the landmark traumatic optic neuropathy treatment trial, have completely upended the old aggressive guidelines.
They really did.
When they actually studied this rigorously, comparing outcomes, what did they actually find?
The findings were incredibly humbling for the medical community. They compared patients treated with erythropoietin, patients treated with the classic high-dose IV steroids, and patients who were simply observed with no pharmacological intervention at all.
And the results?
All three groups showed remarkably similar rates of visual improvement. The massive doses of steroids did not provide any statistically significant benefit over doing absolutely nothing.
Wow.
In fact, one major meta-analysis found a high rate of spontaneous visual recovery in these patients and highlighted a possible detrimental effect to the steroids, noting worse outcomes in some steroid-treated cohorts due to complications.
So what does this all mean for the modern trauma bay? It means we are actively moving away from reflexive blanket pharmacological protocols. We are aggressively prioritizing, first, do no harm.
Exactly.
If the steroids do not definitively save vision, but they do definitively increase the risk of lethal sepsis or ARDS, in a patient with a shattered pelvis and a bilateral pulmonary contusion, you withhold the steroids.
You have to look at the whole patient.
The literature emphasizes that treatment must be highly tailored to the individual patient's risk profile, and that informed consent, having a blunt discussion about the lack of proven benefit and the severe known risks with the patient or their family, is paramount.
It requires a significant level of clinical maturity and restraint for a surgeon to do nothing, especially when a patient is blind. But the overwhelming evidence dictates that observation is often the most appropriate, safest course of action for isolated traumatic optic neuropathy.
Let's shift gears entirely, because physical, kinetic trauma and pressure isn't the only threat to the globe. We have to address environmental and chemical trauma, where the physical appearance of the eye can be the most deceptive, dangerous trap in all of emergency medicine.
This is a critical area.
Let's start with the fundamental chemistry of burns. The researchers break down the distinct, opposing pathophysiologies of acid versus base or alkali burns.
And understanding that distinction is vital because they behave entirely differently on a cellular and structural level. Acids like battery acid, hydrofluoric acid, or industrial cleaners cause immediate protein denaturation and precipitation.
Like cooking an egg white.
Perfect analogy. When the acid hits the cornea, it instantly coagulates the surface epithelial proteins. This coagulation actually forms a physical necrotic barrier, a scab, essentially, that generally halts the acid from penetrating deeper into the anterior chamber of the eye. It causes severe, painful, superficial damage, but its penetration is somewhat self-limiting.
Bases, on the other hand, are an absolute nightmare. Alkalis like lye, drain cleaner, ammonia, or wet cement do not coagulate proteins. They undergo a process called saponification.
They turn it to soap.
They literally cleave the fatty acids and turn the lipophilic lipid bilayer of the cellular membranes into soap. This completely melts the cellular barriers, allowing the alkaline substance to continuously penetrate deeper and deeper into the eye.
It just keeps going.
Right. It destroys the corneal stroma, enters the anterior chamber, chemically obliterates the ciliary body, and physically clogs the trabecular meshwork with necrotic debris, leading to intractable glaucoma. An alkali burn doesn't stop at the surface. It aggressively eats the eye from the outside in.
It's horrific.
So, applying that pathophysiology to the bedside, what does this all mean clinically? There is a warning in the data that honestly gives me chills. You have a patient who takes a massive splash of industrial ammonia to the face. They come in screaming, they are in agony, you aggressively flush the eye, and when you finally get a retractor in to take a look at it, the eye is perfectly white. It's not red, it's not injected, it's not bleeding, it just looks quiet, a quiet white eye.
It is the ultimate false reassurance in trauma.
Huh?
A perfectly white, quiet eye immediately following a severe chemical burn is an incredibly ominous, disastrous sign.
Because it's not fine.
Not at all. What you are looking at is not a healthy, uninflamed eye. You are looking at an eye where the entire conjunctival and episcleral vascular network has been chemically thrombosed and obliterated by the alkali. The eye is white because there is absolutely zero blood flow.
It's dead.
It is completely ischemic. The limbal stem cells, which are required to regenerate the cornea, are dead. The tissue is actively necrosing. The clinical rule of thumb is brutally clear, and it is counterintuitive to everything else in medicine. The quieter and whiter the eye looks after a severe chemical burn, the worse the prognosis.
That is terrifying. It looks perfectly fine because it's completely dead. So the management has to be instantaneous and ruthlessly aggressive. You do not wait for the ophthalmologist to arrive. You drop a Morgan lens into that eye.
Yeah, right away.
Now, having done this, placing a Morgan lens, which is essentially a hard plastic contact lens attached to IV tubing, into the eye of a thrashing, screaming patient whose eyelids are clamped shut in a severe blepharospasm is incredibly difficult.
It's a fight.
You have to use topical tetracaine, pry the lids open, slide it in, and immediately irrigate with liters upon liters of lactated ringers or normal saline. And you don't stop after one bag. You irrigate until the pH in the deep cul-de-sac of the eyelid is perfectly neutral at 7.0 for at least 30 minutes after you stop the fluid.
You have to dilute it completely.
The guidelines also heavily emphasize the need to physically avert the eyelids and manually sweep the upper and lower fornices with a moistened cotton swab. Why is that specific mechanical step so critical?
Because chemical agents, particularly alkalis like lime, plaster, or wet cement, can crystallize or present as solid particulate matter.
Oh, they get stuck.
Exactly. These tiny particles will lodge deep in the mucosal folds and pockets of the eyelids. If you just run fluid over the anterior surface of the eye with a Morgan lens, the fluid will simply wash over those deep pockets, completely missing the particles.
And they just keep burning.
And as long as a single particle of lye is sitting in that fornix, it will continue to leach out base, continually saponifying tissue, and actively burning the eye for hours or days. You must manually avert both eyelids and mechanically sweep that debris out to achieve source control.
While we are on the topic of retained material, we should briefly touch on a different kind of chemical toxicity, which is the long-term metabolic effect of retained metallic intraocular foreign bodies. If you miss a tiny piece of shrapnel inside the eye on your initial CT, it's not just a mechanical risk of retinal detachment, it's a profound toxicological risk to the neurosensory tissues.
Exactly. It's referred to as metallosis. The literature highlights two specific, highly destructive conditions based on the metal composition.
What's the first one?
The first is siderosis, which occurs when an iron-containing foreign body is left inside the globe. The iron slowly oxidizes, effectively rusting inside the aqueous and vitreous fluid.
Rusting inside the eye.
Literally. This causes a classic rust-colored staining of the corneal stroma, heterochromia where the iris changes color, a classic flower-shaped cataract, and eventually the iron ions poison the photoreceptors, leading to severe retinal toxicity and night blindness.
And the second one?
The second condition is chalcosis, which is caused by retained copper alloys. Copper is highly reactive and causes a greenish discoloration of the intraocular tissues, a classic sunflower cataract. And it can trigger a fulminant, sterile, purulent inflammatory reaction that can completely destroy the architectural integrity of the eye incredibly rapidly.
Which reinforces why precise thin-slice CT imaging and definitive urgent surgical extraction by a vitreoretinal surgeon are absolutely non-negotiable for any suspected foreign body.
Non-negotiable.
This has been an incredibly dense, mechanism-heavy review of the pathophysiology. Let's move into a practical Q&A segment. To really solidify how we apply this complex data, I'm going to step fully into the shoes of the listener, the trauma surgeon standing at the foot of the bed at 2 a.m., managing multiple competing priorities, and fire off some highly specific, practical clinical scenarios based directly on the conflicts presented in the source material.
I'm ready. Let's test the clinical application of these guidelines.
Okay, question 1. I have a patient involved in a catastrophic industrial explosion. They arrive with a confirmed, obvious, full-thickness, open globe injury uveal tissue is actively prolapsing out of a scleral laceration, but their face and their eyes are also covered in an alkaline chemical from the blast.
Oh, nightmare scenario.
Right. So as a trauma surgeon trying to manage this holistically, which do I prioritize? The protocol says flesh chemical burns immediately and aggressively, but the absolute contraindications say never apply pressure or fluid to an open globe. What is the actual hierarchy of action here?
It is a phenomenal nightmare catch-22, but the surgical guidelines provide an explicit hierarchy of action. Repair of the open globe takes primary absolute importance over the chemical decontamination. You must seal the structural integrity of the eye first.
So no flushing.
No flushing yet? Why? Because you absolutely cannot aggressively irrigate an open globe. If you hook up a Morgan lens or aggressively flush liters of pressurized fluid into an eye with a full-thickness laceration, the hydrostatic pressure of the fluid will enter the globe and forcefully, hydrostatically expel the retina and vitreous out of the wound.
Just wash it right out.
You will literally wash the internal contents of the eye down the sink. You must place a Fox shield. Get the patient to the OR immediately, let the ophthalmologist surgically close the lacerations with 10-0 nylon to restore the closed system, and then, once the globe is watertight, the aggressive management and irrigation of the chemical and thermal injury follows. Structural integrity must precede chemical decontamination.
That makes perfect mechanical sense. Structural integrity first, hydrostatics second. Okay, question 2. My patient sustained a severe blunt force injury to the orbit from a baseball bat. They have a closed globe, no rupture, but the bedside ultrasound or the CT scan shows a massive traumatic retinal detachment. Does the vitreoretinal surgeon need to be called in to fix this at 2 a.m.? Is a retinal detachment a middle-of-the-night ischemic emergency like a compartment syndrome?
No, it is not.
Really?
And the reasoning comes down entirely to complex surgical mechanics and tissue healing. The literature notes that vitreoretinal surgeons will actually typically wait at least 2 weeks from the initial severe trauma or from the initial open globe repair before attempting to surgically fix the detached retina.
2 weeks? Why so long?
Repairing a complex retinal detachment requires a pars plana vitrectomy. To perform that surgery, the surgeon has to place multiple trocars and infusion ports directly through the sclera into the eye to constantly maintain intraocular pressure while they meticulously peel tractional bands and laser the retina.
I see.
If the eye has recently sustained massive blunt contusion or has fresh sutures from a laceration repair, the scleral tissue simply does not have the tensile strength to withstand that required fluid infusion pressure. The fresh wounds will completely blow open on the operating table.
The tissue is just too friable.
Exactly. They purposefully wait 2 weeks to allow the primary wounds and the contused sclera to heal, form scar tissue, and gain enough structural integrity to survive the massive fluid dynamics of a vitrectomy.
That is a brilliant clinical pearl. It completely changes the anxiety level in the trauma bay, knowing that the retinal detachment, while severe, can wait for elective daytime scheduling. All right, question 3. And this is a scenario every emergency physician and trauma surgeon dreads.
Let's hear it.
You have a 4-year-old pediatric trauma patient who was struck in the face by a dog bite or a blunt object. Their eye is massively swollen shut. They are screaming, thrashing, terrified, and entirely uncooperative. You highly suspect severe orbital or globe damage. How do you handle this evaluation without causing iatrogenic harm?
The guidelines highlight a critical, uncompromising rule regarding pediatric trauma. Do not force an exam that places undue mechanical pressure on the eye.
You just can't do it.
If a child is thrashing, crying, and aggressively squeezing their eyelids shut in a severe blepharospasm, attempting to forcibly pry those eyelids open with your thumbs or with metal DMAR retractors is going to exert massive, uncontrollable pressure on the globe.
Because they're squeezing against you.
Exactly. If there is an occult rupture hidden under those swollen lids, your aggressive physical exam will be the exact event that extrudes their iris and blinds them. If the child cannot cooperate, you stop. You do not force it.
So what's the next step?
You coordinate with anesthesia, and you go straight to the operating room for an examination under anesthesia, or EUA. And critically, you ensure that the OR is fully prepped and the microsurgical instruments are ready for an immediate definitive globe repair if a rupture is found once the child is paralyzed, asleep, and the eye can be safely and meticulously evaluated.
Do not force the exam. Put them to sleep, remove the pressure, and evaluate safely. Simple, safe, and highly effective. This brings us to our summary, conclusion, and application for future practice. We have covered a massive amount of highly specialized, mechanism-driven ground today.
We really have.
We translated the granular ophthalmologic data from Millet, Reiser, and Moiseides into the high-stakes reality of the trauma bay. We discussed recognizing the 5 deceptive signs of an occult rupture, particularly understanding the fluid dynamics of why a lower intraocular pressure is a glaring sign of a deflated, ruptured globe.
Crucial point.
We established the absolute clinical mandate for immediate bedside lateral canthotomy when compartment syndrome is suspected. We do not wait for the CT scan, we respect the ischemic timeline, and we save the optic nerve with a pair of scissors.
Yes.
We broke down the exact neuromuscular pharmacology of why succinylcholine is absolutely contraindicated due to extraocular muscle fasciculations mimicking a fist squeezing a water balloon. And we learned to deeply respect and fear the deceptive, ischemic, quiet white eye following an alkali saponification burn.
The overarching unifying theme here is that the trauma surgeon's immediate bedside decisions in those first chaotic 5 minutes dictate the patient's lifelong visual function.
They set the stage for everything else.
Exactly. The ophthalmologist might do the elegant microsurgery days later, but whether there's actually any viable functional tissue left to save is entirely determined by your triage decisions, your choice of paralytic agent, and your willingness to decisively cut a canthal tendon without the safety net of a CT scan.
Which brings us to our final provocative thought.
This raises an important question. We've learned today that in ocular trauma, a quiet white eye following a chemical burn can actually signify total vascular obliteration, stem cell death, and impending necrosis. The tissue is actively dying, but it looks clinically stable simply because it lacks the dramatic presentation of hemorrhage or angry redness. It forces us to ask a broader, more philosophical question about our approach to critical care. In the high adrenaline, chaotic environment of the trauma bay, how many other seemingly quiet or stable clinical presentations, like a soft abdomen, a normal initial lactate, or a quiet airway, are actually masking catastrophic underlying ischemic or hemorrhagic events simply because they currently lack the dramatic, bloody presentation we are so heavily trained to react to? It's a profound reminder to always trust the kinetic energy of the mechanism of injury, not just the visual presentation at the bedside.
A quiet presentation absolutely does not equal a stable patient. That is a thought that will stick with me on the next shift and hopefully change how we all approach the deceptive calm before the crash. That is all for this deep dive into the maxillofacial and ocular trauma literature. You are now armed with the critical edge. Until next time.